And we've had some questions about clinical practice guidelines. And I know that this is kind of hard to grasp sometimes, because we want for there to be we want there to be an answer. We want to know black and white what is right and what is wrong. And I had one student ask a question in there, and they said, which one's right? They're dueling. Well, they're both right. I'm sorry to say they're both right, but I remember when I taught undergrad, there would be a conversation about what is normal blood oxygenation. And some resources would say 96 to 100, some would say 94 to 96, 94 to 100, and they would be different. And students would say, now I want to know what is the right one. And it always comes back to patient condition. And I know that that's kind of a cop-out. It sounds like a cop-out, but it's not, because you're going to see what we call dueling guidelines. You're going to see one person telling you, one group of experts making these recommendations, and another group of expert making these recommendations. But it all depends on your patient, your population, your setting, all of those things, your patient condition. So you know that clinical practice guidelines are produced by major professional organizations, and those are going to sound like the American Heart Association, American Diabetes Association, American Association of Clinical Endocrinologists, those type of things. There are also clinical practice guidelines, which we call CPGs, that are produced by smaller specialty organizations that often address special populations or smaller populations. For example, you'll find hypertension guidelines for African Americans, you'll find them for pediatrics, you'll find them in the diabetes guidelines, you'll find hypertension addressed. You're going to find different guidelines in different places. And guidelines, clinical practice guidelines, are written by professionals, experts on a panel in a professional organization. And it sounds like American Association of, okay? Then you have people that are reporting on clinical practice guidelines. Those people reporting on clinical practice guidelines are something like Medline, Dynamed Plus, Epocrates, Hawyer, UpToDate. All of those different references that you find are looking at the clinical practice guidelines, which are the original recommendations, and then they are reporting on them. And sometimes these references that you read will report on more than one guideline. If in Corpus, we had an event the other day. It was talking about lipids, and the pharmacist that was teaching us, she reported on 4 different clinical practice guidelines with recommendations. And that's what you're going to find. And my recommendation, and what I've tried to get you to do, is to read the baseline clinical practice guidelines. And Bataro has those, and then also the baseline, like American Heart Association, those type of things, those clinical practice guidelines, so that you can learn the base of your pyramid before you work your way up. And your boards are going to test you on the base. And the base is a safe clinical practice as you move forward. Okay? And then as you move forward, let's say you get your license, or you're studying and you're doing a clinical rotation in pediatrics, and you have an obese patient or one with hypertension, then you're going to be introduced to those other guidelines for a special population. And that's the best approach towards learning to practice as a nurse practitioner and studying for your board exams. And that's what I've tried to do. So that's why I've asked you to answer in this course, to make most of your references from the assigned guidelines, the assigned readings, and then move out from there. So does that make sense? I know that it's tough when you see differing things, and somebody will pull out something from emergency department guideline and say, well, this is what we do with hypertension, but when what we assign in these courses are aimed at primary care, and you're safe starting with the assigned readings. And so that's my soapbox. And just trying to explain of it, what do we make of it, and why is it that way, and why can't somebody just answer the question, and we're trying to, but it's not that easy. Okay, let me see if there's anything. Dueling clinical practice guidelines, we got that. Okay. So in this unit, there's a lot of pharmacology, and I gave you the medication study guide, which was basically just telling you to learn by the classes, right? If you look at the medication study guide, you'll notice that I've asked you to study the drugs by the class. Especially in cardiovascular, you're going to see that all of the guidelines don't talk about medications by a medication name. They talk about them by a class. And it actually makes it very easy to learn, because you have a prototypical drug that is most consistent with the drug class, like lisinopril or labetalol. And you're going to have that prototypical drug. And if you know the extension, like amlodipine, pril, those things, the extension on them, then you're only going to have to learn one drug and the class. And that is going to help you to refine your studying, so that you're not sitting there trying to remember all these drug names and what is a beta blocker. Just learn amlodipine. It ends in pine. Anytime you hear the pine, a calcium channel blocker, anytime you hear that, you're going to know it's a pine, is a calcium channel blocker. And then you can find that then when you study the guidelines, then you can remember, well, calcium channel blocker, ACE, ARB, hydrochlorothiazide, HCTZ are first for hypertension. And I don't know how else to say it, but if you study them by the class, you are going to be it's going to be so much easier for you. Then make yourself a little flashcard and say, what is a calcium channel blocker? And you can put some names on the back if you want to, just to flash it so that they are in your brain. So that if you see first line for hypertension, you'll know that it's not a beta blocker. And you're going to know that there's a bunch of other drugs you can use. And so probably they would say, what is not first line for hypertension? Because they're in the course, you had some quizzes, and here's one of them. Just put these questions in here so you could look at them. And these are pretty easy questions, because a lot of them are knowledge-based rather than application. A patient's being treated with an ACE inhibitor for hypertension. ACE inhibitors should not be prescribed concurrently with the following drugs. There's something wrong with this question, because anytime you hear the should not be prescribed, the next thing you're going to do is you're going to find a patient that is on an ACE inhibitor and a potassium sparing drug, because ACEs and ARBs are potassium sparing. And their potassium level can go up, especially if they have renal failure. Thiazide gets rid of electrolytes, including potassium. Beta blockers, no effect. Calcium channel blockers, really no effect. So potassium-sparing diuretics like aldactone, that's really our one. And that is the correct answer. So you all probably already know that. Which health problem an example of target organ damage? Now, I got this question. I think I inherited this question. I didn't really, I would think, if you have somebody who is I always think of target organ damage when I've got a patient with hypertensive urgency or emergency, that's what we're going to look for. We're going to look for the eyes, we're going to look at the chest pain, renal, no urine, those type of things that show that this person's having target organ damage. But if you think about it, left ventricular hypertrophy is absolutely target organ damage from hypertension, but it's more long-term, right? You can kind of, get the heart to get a little smaller with getting the fluid out and things like that, but you're not going to see that in the clinic, when you're looking for target organ damage. So this is a little bit a little bit of a weird question, but target organ damage doesn't mean just right now. It's any target organ damage over time. But probably you're going to see more when people talk about target organ damage. You're going to think about hypertensive urgency or emergency. Okay, what is this type of blood pressure? What is this patient has 160 over 88. We know that's isolated systolic hypertension. Why does that happen? It happens because of a peripheral vascular resistance as we age. So you'll see that in the classic treatment for this is a calcium channel blocker. We'll use that. A patient with increasing renal insufficiency would have concerns about starting which medication? And that's spironolactone, potassium sparing. Remember renal, your potassium's going to go up. And these are kind of easy questions. Well, maybe they aren't for you. Sometimes I think faculty become hard question blind. And they all start to look easy after a while because we've got the key. I know what the answer is right here. So it makes perfect sense to me. And then over time, we had this discussion in the class a little bit about that intuitive knowledge. And for those of you that are really young, I'm saying really young in your 30s and 40s, you're learning this stuff at a fairly young age when your brain is still really good. But when you learned it in the 20s, say, or your teens, let's say you went to nursing school, you started nursing school at 19 or 20, and you learned this stuff, you learned nursing so well that now you own that knowledge. It's in your brain and you don't even know how you know it. You just know it. It's there. And when you need it, it comes out. You don't have to think about where it comes from, how you learned it, anything like that. And that will happen with your nurse practitioner knowledge too. So that you can just look at this and say, well, clearly, Lasix is not going to bother a patient because that gets rid of potassium with renal. Anytime you're talking about electrolytes and renal insufficiency, you're going to talk about potassium. Okay, but right now you're learning this information and you don't know it all that well. You know it, it's in there, but it hasn't got to the intuitive level where it just pops out. Okay, but you're going to be developing that over time. And when you take a test question, I know I've said this before, but I want to say it again, is that because you have learned and you have studied for this unit, when you see a test question and you think you think an answer is correct, you think, I just have this gut reaction to this answer, but I don't know how that I know it. I just think it's right. And that's what some of this is going on there. And it's not a feeling. It's your knowledge. It's knowledge trying to tip you off. And so if you're guessing at a question, and usually your first response, your first response is right. But if you start to second guess yourself and say, how do I know this? Let me think through this. I'm going to talk myself right out of it because I don't know the answer and I'm going to guess again. That's when there's a problem. But if during the test you think of something, you remember something, because sometimes that one question will remind you of something else, because an answer will sound like it belongs with another question, and then you'll start to get there. But you will get intuitive about this too. Don't worry, it'll come. Probably, sooner than you think if you do it enough times. Okay, so this just asks about, that one was just asking about isolated systolic hypertension. Okay, and this isn't, just know that when a woman becomes pregnant and she's hypertensive, we need to change her medications. Some of these medicines, the ARBs and ACEs are really bad for growing babies. It messes up the renal system. Okay, any burning questions on hypertension? I think that's pretty. I think it's easy for some people, and because they do it all the time, but others, there's a little bit more learning. So with chest pain and coronary artery disease, you're going to want to know the definitions of them. You're going to want to be able to recognize when you have unstable versus stable, chronic stable angina. Those are some of the main things. Know how the medications, the mechanism of action of the medications are really important, because then you can think through them. Does this medication dilate the vessels? How is that going to help my patient? Why does a beta blocker help them? All those things to, reduce oxygen demand, all of those things, so you can start to think about it, so that when you see a patient that's on a drug, you'll be able to very precisely go backwards and figure out what the indication is from their history and from them. We had a patient, I saw a patient with a student the other day, and the patient was on Deltazem, and I forget which other med. It was something that we give for, it looked like the patient had either had an MI or had atrial fibrillation, or maybe both, but definitely had a major cardiac history, and he denied any cardiac history at all. But patients don't get on those drugs, because you've studied the guidelines. They don't get on those drugs just for simple hypertension. Those are serious medications. So know your chest pain, know how to rule in, rule out the different types of angina, and that type of thing. Any questions on coronary artery disease? Just jump in if you have questions. Heart failure, you're going to want to be able to understand the therapies for heart failure and how they work, the mechanism of action. And the main thing that heart failure is it's pump failure. It's the pump is not pumping water. They have water backing up all over the place. And the way that we help symptoms of heart failure is a diuretic. We get rid of fluid. So you're going to see diuretics, Lasix. If you see a patient on Lasix, you're going to know, from my experience, when I see a patient on Lasix, this person has heart failure somewhere. They usually will not give Lasix for simple edema in primary care. So if you see a patient coming to you on beta blocker and Lasix, you can probably bet that they may have had a heart attack, MI, and they probably have some heart failure there going on. So know why you give an ACE and ARB, why that's good for heart failure, and know how to treat the symptoms of heart failure when they come up. And those are pretty basic things. I don't think you're going to do much staging on anything. That's if there's a test that has you, not necessarily my test, but even the boards, if they have an exam, they're probably not going to expect you to memorize a huge chart. You might want to know that A and B are risk, C and D are symptoms. So if you hear a patient's in stage C or D, D is in the hospital. So C is what you would see, a patient that was previously has a diagnosis of structural problems with their heart, and now they're symptomatic. And you can a lot of times keep them out of the hospital by treating them. And these patients, heart failure patients, coronary artery disease patients, you will be co-managing them with cardiology. I hope you are. There's going to be times when let's say you're working on the mobile van, the Mission of Mercy van, and you got all homeless people, and they're coming into this van and they have no resources at all, and they're in heart failure. You're either going to send them to the hospital, or you're going to, or try to get them out of their symptoms and get them back into stage B. But usually you have some resources, and you want to try to get these patients in with cardiology, because you don't want to take responsibility for them. And if they have to go in the hospital, you want them to have the resources there to admit them and all that. So digoxin and furosemide is just going to lead you to dig toxicity. Low potassium and digoxin together leads to dig toxicity, and that has to do with the eyes. They see halos. So that's always a wonderful question to ask. I don't think I'm asking it, but that's something that it's one of those nursing questions that even though you're learning to prescribe, you still have to know you don't want to prescribe. If you have those two prescribed together, you're going to watch for DIG toxicity. You're going to monitor DIG levels and look for toxicity, signs of toxicity. Okay, lipids. I would be sure to be able to know your patient. In adults, this is an adult chart. You're not going to have to calculate ASCVD risk. That's an equation. We're not going to have you do that. But know if a patient, when they're going to jump off or jump on to this treatment. And you can see it happens, there's a lot of statins prescribed. The prescribing for statins has gone up a lot, and there's a lot of criticism about that. But know if they have ASCVD, right away they're going to statin. If they have LDL greater than 190, yep, they're going to a statin. They have diabetes and they have high risk, yep, they're going to statin. That or a moderate or high. Everybody's on a statin, right? If they don't have any of that other stuff, then we're going to go down to calculate their 10-year risk. Then we're going to give them a statin. And always lifestyle modifications. So really the key to this, you do not see any low dose statins on there, right? So I would memorize some of the moderate and high intensity statin dosages. That's what I would do. I would go ahead and do those and know that, if you're a diabetic, it's moderate or high, and LDL great, it's high, moderate, and so just kind of know where does the moderate lie. Okay, so they have ASCVD greater than age 75. Now there is a separate guideline, of course there is, for older adults for statins, and that's put out by I think the Geriatric Society. And so there's a caveat there, and I work with old people all the time, and so I don't start a statin at all unless my patients are admitted to the nursing home, and the average life expectancy is 2 to 4 years, and this is long-term prevention. Statins are long-term prevention of ASCVD. So 10 years, you want to figure, well, I'm looking at 10 years life expectancy to have any benefit. So, but don't do that. Just say if they have ASCVD and they're greater than 75, then you're going to have a lower dose statin. Okay, not low dose, but moderate. But if they're less than 75, go with the high intensity statin. All right, let me see if there's anything else on there that I wanted to make sure that I told you about. Okay, I think we've talked that to death. Okay, but let me know if you're okay. We can't see the whole chart. They're getting gray boxes on the top of it. Okay, can you see the test question now, or this quiz question? I'm not sure if maybe that it was just not clear. Sometimes but we're going to go. The chart is in. I posted in the course, and it's in the ACC AHA guidelines. It's real clear. That's the best thing to look at for the lipids. Okay, so severe lipidemia in children. All right. So we're used to seeing percentiles, right? But if you look at well, I'm looking for okay, here it is. This is the Dynamed Plus one. You can look in here and look at the risk assessment. You can look at there's a little chart here that shows whether they have acceptable, borderline, or unacceptable. And children starting on statins are it's kind of a last result for children, last resort. And if you have a child that's doing lifestyle modifications, they're say they had hypertension, they had obesity, And they also have some lipid problems, and they're already, they're being treated, but they're growing, and their percentile on their weight is improving, and their blood pressure is improving. Then you want to probably kind of keep monitoring the lipids. So you don't want to put them on a statin. It's kind of a last resort. Okay, so just read through this stuff here, and always remember with children, it's lifestyle, 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 and with adults too. It's always lifestyle, but especially with children, because the education of the parents and that, because we can make a difference, I think, even more in children with lifestyle, because we can control that more. The parents can control that more, and so they can get better if the family's in on it. So always remember lifestyle with the children. Okay, and so it's greater than 190 is the answer there. Anticoagulation, I did that little YouTube presentation for the anticoagulation. And I always say, this is not a comprehensive review. You hear me say that a lot, because it doesn't mean I don't want you to look at anything else. I just want you to kind of start there and keep going. So a patient on Xarelto, what monitoring do they need? Nothing, right? You just monitor for bleeding. That's the main thing. Look for bleeding, but you're not going to monitor any of these other tests like that. Okay, and a patient, warfarin INR 9, he's on warfarin INR 4.96, and you always see all the labs that says 2 to 2.5, 2.5 to 3, depending on why they're on the medication, what the indication is. But in this case, you're going to want to stop the Coumadin or hold it, and then monitor the INR. So you're not going to want to give vitamin K. It has to be it's going to be sub-Q, but you're going to want to give it when it's severely high, and there is guidelines for that. You can look that up. Less than 5, and no bleeding. You're going to just hold the Coumadin, monitor the INR, and then restart the Coumadin at a lower dose. Look for those interactions. Look to see if they start an antibiotic. Why is there going to be a long-term medication that caused the INR to go up? Or is it just a temporary, they had an infection, so now it's messed up their INR. Okay, you can see this one, a 48-year-old male's in the hospital for CAD, stent replacements. He's on both clopidogrel and aspirin. And you're going to see Plavix and aspirin all the time. And that has to do with that clotting cascade. And I'm not going to go into all the details, because first of all, there's not room in your brain. And second of all, just know that they're given together all the time, right? You'll see it in clinical practice all the time. You could clarify the medication orders. You could teach the patient about bleeding. Are you going to schedule PT/INR? No. And are you going to discontinue meds? No, because there's a reason why the cardiologist, there's a reason why they started this, and he just came out of the hospital. So you're not going to stop I always have kind of a rule that if a cardiologist or another practitioner, specialty, psych, or somebody like that started a drug, I'm not going to run off discontinuing it at will. I'm going to find out, if I think there's something wrong. Like I had a patient the other day that was on inhalers, and she was on albuterol nebs and albuterol MDI, and she had albuterol everywhere. And it wasn't just PRN. And so she came out of the hospital like that, so I had to clarify that. But generally speaking, when you have cardiac meds, you're going to want to find out why they're on it. If you have a question, don't take action. That's my advice. Okay. So 70-year-old patient is taking Plavix, 75 milligram, and what do we know? The daily dose for clopidogrel in adults is 75 milligram, regardless of if they're elderly or not. Even if they have renal impairment, it's always 75 milligrams. Okay, so you always hear that with old people, start low and go slow, but that doesn't count for that drug. Okay, abdominal aortic aneurysm. Know who needs to be screened, how to diagnose, when do you refer. That is pretty straightforward. You know, developing that skill to be able to do the physical exam, know the signs of, you know, an emergency. When is it an impending rupture of an aortic aneurysm? What, you know, those things that can kill people, and something that everybody should know. You know, those are the things that they love to put on the boards. You know, something that every patient should know, or you should tell everybody, or you should know to be safe. And then something that could kill somebody, like, is it impending rupture? Cardiac arrhythmias, I think I mentioned this already. There will be a few rhythms on there, but you know, it's kind of hard to see the rhythms on the screen that well. And so they're going to be rhythms that, you know, that everybody should know, and or could kill somebody, or, you know, things like that. So you're going to want to look at rhythms, but don't feel like you're going to have to diagnose a second-degree bundle branch block or something like that. No, it's more, and it's more of the patient has this rhythm, what would you do kind of thing. Not, you know, not get out your calipers and count squares and things like that. Okay, there should be easily recognizable to you. As far as cardiac arrhythmias, the book kind of goes through them very nicely. And the most common ones you're going to see are atrial fibrillation. You're going to see that all the time. You're also going to see bradycardias. You're going to see that a lot. You're going to look for drugs, blocks, things like that. So any questions on cardiac arrhythmias? I was never one, even though I worked at the heart hospital, I had a telemonitor there. I had a telemetry person there. And I had cardiologists running all over the place, and I was never one that was one of those that I could pick up a strip and just tell you all about it. And I'm sure we have people in this class that can do that. And I think to be able to really understand the EKG, you know, every time you take an EKG class, they start talking about cutting the heart on planes, and how this lead shows this. It just is like, I am brain dead to geometry and spatial relationships. So if somebody can, you know, I can recognize the deadly rhythms, and I think that's important to be able to do. But as far as in primary care, you know, you're going to ship them out. If you have a deadly rhythm, you're going to get them out of there as soon as you can. Okay, so you're not going to be managing these rhythms, but if you have a patient come into your clinic who has chronic AFib, you want to make sure that their rate's controlled, they're asymptomatic, and that they're anticoagulated. And if they're not, then you need to do something. You know, refer them to the cardiologist, get them on an anticoagulant now. If it's a new AFib, then you're going to definitely get them out of there, especially if they're symptomatic and their rate is not controlled. You know, you want to anticoagulate them. So there was a question in the course about a course of action for a new AFib. And so that is a judgment. And most, you know, every nurse practitioner in Texas has a collaborating physician. A lot of times you work in a clinic that they're not there, but you have them by phone. And so if you have, you know, you could tell them, I have a patient here, he's 60 years old. I did an EKG because he has high risk, and I found AFib with rate control, and he's asymptomatic. And you can say, what do you want? What would you recommend? And he may go ahead and send me to the hospital. But he may say, let's get him into a cardiologist. Let me call so-and-so, he'll get him in, or whatever it is. It depends on the patient. It depends on the situation. And that's why a lot of times when you have these scenarios on questions on the test, it is really kind of hard to get enough information in there to make the question without giving the whole thing away. You're going to give the whole thing away by giving them so much information that it's really hard to do these kind of judgment questions, and because every patient is individual. And it also depends on the patient's preferences. You know, will they go? I don't know. We'll see. But anyway, yeah, somebody said, please don't send every new AFib to the hospital if they're not symptomatic. and that probably comes from an ER person. So they, if any of y'all are on there, you can tell us what happens if an AFib, asymptomatic, comes to the ER. Anybody here that works in the emergency room? Okay. So valvular heart disease, you're going to have to know about dental procedures. You know, when do you do prophylaxis? This is what really, is important to know is, in that little lesson that I gave you, it talks about the three things, the listening point, the amplitude, and where it is in the cycle. And if you know those things, if you know if it's a diastolic and you know the major listening point, and you know the amplitude, you know a lot. And I could see in some of your questions that you wrote that people were keying in on that they could say, well, there's only two, there's only two systolic murmurs that you hear in that spot, so it's got to be one or the other. So that's really good, because when you can walk into a patient's room and you can say, oh my, I have a second intercostal space, grade 3, and it's a systolic murmur. Boy, you can just look it up real quick, and you can just go out there and just tell them just what they have. So all new murmurs should be evaluated by a cardiologist unless they're benign. And those are some of the things you need to learn very, very well, because those are favorite questions. Benign murmurs in children. Read about those, the venous hum, and I put some information in the discussion board about that. Kawasaki's disease, you all put a really good picture of that in there, and a lot of times you'll have patients come in with a history of Kawasaki's, and they're still having thyroiditis, things like that associated with it. So if you have a new Kawasaki's disease, that's a different picture than somebody that has a history of Kawasaki's or still suffering with sort of the sequelae of Kawasaki's. Well, I hope I didn't bore you to tears, and be sure and listen to that other one. You may hear a little bit of repeating, but I think there's probably more information in there that might help you too.